Thank you everybody for attending this LADUCA sponsored lunch. We've been lucky enough to be at the FSC conference now for a number of years. I think this is year number 4, so we've had some really, really great topics in the past. But yeah, I think this one is probably an important topic that might have been overlooked in the scheme of conditions and illnesses prior to during the pandemic. So I think we'll get started and let our subject matter experts get cranking. So I'd like to introduce Ingrid Thorn, who's the Head of Underwriting and Claims Australia, New Zealand for Swiss Re, and also a board member for LADUCA. Who has graciously agreed to join us after a whirlwind Southeast Asia tour and some wardrobe mishaps as well.
I do, and I actually am not claims, but sorry. Just to make sure. I have a very helpful claims counterpart at Swiss who's given me some tips, so not an expert on claims.
But you do need a trauma claim.
yeah.
Cool, and Dr. John Mayhew, who is no stranger to a lot of people in this room, is Chief Medical Officer of AIA, who has spent a number of years with some of our prominent sports teams like the All Blacks and the Warriors, and most recently Harbour Rugby and the Kiwis. Perfect, excellent. So hopefully with these excellent subject matter experts, we can get some ground room in the in figuring out what's going on in the orthopaedic claims space. So I think the first question I have will be for Ingrid, and it's we know from a macro perspective that that orthopaedic claims, and especially areas in terms of spinal things, might be an issue. What trends are we seeing in the Australian and New Zealand market?
Oh, thank you. And I am going to just refer to my notes for some of these more claims answers here. So in the 6 months to date of 2022, we are seeing a higher proportion of musculoskeletal claims, but at the same time we're also seeing a decrease in the number of accident claims. So we're sort of looking to see if this is perhaps a latent impact from COVID, with people returning to work from the office, having changes of their ergonomics, what has been perhaps the impact of their home setups, and do people really want to return to the office as well? Like what we're seeing in Australia with mandated returns to office, some people have got very comfortable with their new way of working from home. We're also seeing a higher proportion of musculoskeletal claims closing, which is a positive, but that's really the importance of the early intervention that the claims teams are doing, and what we're seeing is the insurers across Australia and New Zealand are doing a really good job of that early intervention and being able to close those claims there. And I know you sort of start to see when you've got your primary and your secondary causes, but we've done a recent white paper on mental health, and we are seeing that there's a larger proportion of those claims, and so naturally you get a decrease across the proportion of musculoskeletal claims. So it's sort of a little bit about the primary and secondary and how they can compound. That's really it. And I guess there's sort of some new hypotheses too around if during COVID we have actually starting to be better with our health and more proactive, and so will we see some, improvements in musculoskeletal, but it's really just a new hypothesis at the moment and something that we'll follow.
Excellent. And Dr. Mayhew, in terms of the clinical side of things, are we seeing what's the current medical trend that we're kind of seeing? How are we treating these? Because I know for a long period of time, spinal fusions and things like that were the way to go. Is that still the case?
Yeah, I mean, I think just to give us some background, I think we're a population which is gradually getting older. People are living longer. We're much better at treating cancer and heart disease. So people are now getting the benefits of being able to live long enough to get degenerative joint disease, back problems and things like that. So we've got a tsunami of people, my age and older, who are, getting degenerative joint disease, so they need to be dealt with. Medically, we're dealing with them much better now, and certainly someone who has a hip joint replacement, possibly 4 to 6 weeks off work, possibly a lot less than that in sedentary work, total knee joint replacement, which is a common operation. You mentioned about spinal surgery. Spinal surgery needs to be done for the appropriate reason. In the past, a lot of people with chronic lower back pain have had spinal fusions thinking it'll cure their back pain. It doesn't normally do that. You've got to look at other things for that. Spinal fusion is an important operation if you've got an unstable back. If you've had 2-level discectomy, you may need to have that after having disc surgery to relieve sciatica. But a spinal fusion for back pain, get a second opinion would be my advice from anyone who's been advised to have that. So obviously in terms of costing now, orthopaedic procedures, and COVID hasn't helped it. We've got a huge waiting list in New Zealand for non-urgent orthopaedics. They're getting more expensive. The prostheses and things like that are very expensive. But interestingly, hopefully, the time off work will be less. People will be returning to work, and one of the maxims in orthopaedic surgery is getting people going. If you have a hip joint, you're walking that day. You're getting moving. Inactivity is, not good for you. And it comes back to that truism we say, diagnosis doesn't mean disability. You can have a stuffed hip, have it repaired, but you can go to work. So diagnosis and disability are different things.
Perfect. And I think on the back of that, and going back to what you said, Ingrid, about mental health, are we seeing quite a lot of, and I guess given the recent conversations that we've all had about sustainability of certain products such as disability, are we seeing a lot of, and I know claims isn't really your realm, but a lot of secondary mental health claims coming as a result of musculoskeletal issues?
What we're seeing in our recent sort of research, or just our recent experience studies, is that accident has a lower termination rate than sickness. When we also measure musculoskeletal as the primary cause. So what we are seeing too is that if someone does then have a secondary claim, it actually then follows the experience of sickness. But it's where they still have both conditions that you get all of those compounding. I think when John's talking here about the surgery being able to recover so quickly, many of our claimants we would expect to perhaps not meet even their waiting periods and are returning to work during that period. So when you have someone particularly with a musculoskeletal injury, how long is it taking them to return to work? It's once people get past the 30, and particularly in your white collars, past that 90-day, it becomes much more difficult to influence, and that's where you start to get those longer claims.
Can I help you out there?
Sure.
We do see a reasonable proportion of people now who have a musculoskeletal condition have that adequately treated and still can't get back to work. They have a chronic pain syndrome, chronic regional pain syndrome, things like that, which is often quite hard to understand, and hence the reason for early mobilisation. And it's certainly the longer someone has off work, the harder it's going to get them to get back. But we do see a lot of psychological ramifications of things that you think, well, why can't this person move their ankle properly now? Structurally it's fine, and there's things like that. And I think, we see it, and we can almost predict, people who have adverse risk profiles, they may be unhappy in their work, recently divorced or separated, other health problems, blah, blah, blah. Certain occupations in the medical industry is not immune from that. And we can predict the people who will have, a prolonged recovery from orthopaedic procedures, and to the extent that a lot of spinal surgeons, they won't operate on people who smoke, because the risk of side effects and complications is so high. Don't ask me why, but it's a known fact.
And another one on that too is obesity, and from an underwriting perspective, when we're looking at persons' BMIs, and often it's something where we just simply say it's a plus 50, but when you're starting to look, and this is the importance of that holistic profiling around what impact can someone's weight have on their ability to recover. And it was interesting when we were doing our most recent update to this and speaking to our claims counterparts. And is a BMI something that's captured on everyone's claim form? And it's more something that is collected anecdotally, but actually it really does influence the claim duration. So it's something that we need to link closely a little bit more from underwriting and claims, because we do appreciate that it really can have that important impact on duration.
It was interesting, I was at a meeting recently of the New Zealand Orthopaedic Association, and one of the leading spinal surgeons there says he refers more patients to bariatric surgery than he does spinal fusions. You know, so basically it's to look at the other things, and an operation is not always the cure for especially back pain. But it was quite an enlightening fact, and it adds on to what you're saying. You've got to look at the other factors involved. Back pain is not straightforward.
I guess just putting you on the spot again, sorry Ingrid, just a more of an underwriting centric kind of question. Do you feel that we're doing enough from an underwriting perspective to kind of triage the risk here, or do you think it's I guess too hard for people at a time of it, like when we're assessing applications, for us to, because I find it's easy to slap a plus 25 on a lot of these things, a borderline standard rubber stamp on a lot of these things. Do you think our underwriting approach is a bit too soft with back pain and comorbidities that you've seen in the Australian New Zealand market?
Well, I think what's always interesting is when it comes to musculoskeletal conditions or back, we exclude. So we never get to actually understand would they have needed to claim. So it's a little bit the same thing we come up against with mental health. So it a little bit does rely on us just looking to the normal statistics and things. But look, underwriting, we always look to someone's history to try and predict what will happen. COVID really got us rethinking sometimes how we underwrite. But when I think like musculoskeletally, we look at proxies for severity to try and give that really objective measure, because, you know, and can we then link that back importantly to an evidence base to actually substantiate the decision and what we're doing. So I think when you look at it, we always sort of focus on the disability and we look at things like time off work, but do our questions and the approach we take do enough to assess someone's actual capability and their ability to function? I think when I was thinking ahead of this session, and if someone was perhaps born without the use of a limb, we don't exclude it, quite obviously, because they've lived their life and are functioning very capably without the use of that limb. So we don't typically exclude it. But yet if someone has an injury to a limb, perhaps within sort of 3 to 5 years, we take quite a different approach there. So is it that we should be thinking more around capability? With the introduction of online rules engines as well, we're seeing quite a shift from some of the standard questioning, which is, have you ever had a sore back? Which have you had it in the last 5 years, or have you had it in the last 10 years? But I think perhaps, again, they don't necessarily capture the right risks. If we had someone that has had a history of spinal surgery, it was 15 years ago, but they are in a manual occupation, it is important that we do the right thing at underwriting as well. So it's not as simple, but I think we can continue to improve it. And I think, as John touched on, trying to understand someone's biopsychosocial circumstances is really important. What is their workplace like? How are they functioning? What have they got around them? So again, that holistic profile of someone all feeds into it, and quite difficult to assess on a piece of paper as well.
Yeah, and following on from that, there's not many orthopaedic procedures that need more than 4 to 6 weeks off work. You know, I mean, you can have a joint replacement, and I think following what you're saying is that perhaps people with a gammy hip and they've had abnormal illness behaviour in the past, are we better to put a loading on that policy rather than an exclusion? Because they can have their hip joint replaced, but if in the past they've had glandular fever and taken 6 months off work afterwards, or they've had a procedure and took a long time to recover from that, that's mostly more pertinent than anything else. So illness behaviour is very important.
Excellent, excellent. So I guess we talked briefly over disability cover, but I think one of the other big products that will be affected is the private medical cover space. Now, some of these treatments are astronomical. In terms of, I guess, the costing, and you've said that spinal fusion treatments and spinal surgeries are now going down because the efficacy of them is questionable. Are we still seeing quite a high impact of pricing on private health insurance?
Absolutely, and I'm sure people in this room would know that the prices of total hip joint replacement have actually gone up 20-25% this year. And you think, well, why has it gone up that much. And interesting, I was with an orthopaedic surgeon on Monday night, and he can't understand how in the public system his colleagues can do 2 knee joint replacements in a session, and in the private sector they can do 6 to 8. So there's lots of other factors going on, but the cost to us of the prosthesis and things like that is quite prohibitive, and medical insurance is something that we all need to have, but the price is becoming very, very costly. It's almost too expensive to have, but too expensive not to have as well at the same time. But these prices are going up, and as an insurer, wearing my insurance cap, we don't know the actual cost of some of these things that they're putting in. We know what we're being charged, but to try and find out what they're buying it for and there's all sorts of mysterious fees we pay for, which I won't go into.
Excellent. So I guess outside of surgery, and you'd probably know better than any of us from a clinical point of view, how are we treating spinal disorders or orthopaedics in general now? Now that we've learnt that some of these surgeries just aren't effective.
Yeah, I mean, I've got to be careful here that not all spinal surgery is bad. I'm talking about fusions and things like that. Now there is an indication for fusion, but it's like in medicine, we've got to make a proper diagnosis and then devise evidence-based treatment, and that treatment may be, okay, you've got a very sore back, but you've got a BMI of 40, you don't do any exercise, if you lost 10 kilograms, your back pain, your knee pain will improve. We can help with medication and things like that. So as Ingrid mentioned, we need to have a holistic approach to management, and we all want the instant cure, don't we? We want the tablet or the operation or whatever, and as some of my physio friends say, the operation is a bit between prehab and rehab, really, and the important part is what you do after the operation. And people often say to me, how come that this famous rugby player gets back at such and such a time, and the lady down the road takes 3 times as long? It's because they've been doing the rehab, they've been working hard, and sure, they haven't got a job to go to as well, but it can be done, but it's doing the appropriate rehab and prehab.
Right. Yeah, and I think that I guess just asking a further question, that rehab is quite a big avenue on the Australian insurance market. I know that in New Zealand we talk about underwriting and claims, but over in Australia rehab is a big thing, and they have separate departments for it. So I guess from a rehabilitative point of view in insurance, what would be the plan for clients on long-term, say, disability claim? Oh, you probably don't.
I'm going to throw to my friend Angela. No.
Shall I take that?
Yeah. Take that.
It's not fair on Ingrid. I mean, certainly, if someone's going back to work in 4 to 6 weeks, we mostly won't put a rehab program in place. But certainly with mental health issues, we'll often arrange CBT, cognitive behavioural therapy, and exercise program. If someone's got a long-term back issue, we will certainly pay for rehabilitation treatment. We're fortunate in New Zealand that a lot of musculoskeletal stuff is done under the auspices of ACC, so a lot of the rehab can be done by an appropriately trained physiotherapist or physical therapist. But it's very, very important. I mean, if you've had a rotator cuff repair, which is a major operation, which we haven't talked about, because that's another one which, your recovery can be 6 months, and then you need to be guided by somebody who knows what they're talking about. Otherwise, you'll ruin the repair or get back too soon. So, it's very, the rehab is very, very important. And sometimes in some of the conditions, because it's not ACC funded, we don't fund it enough, and I think that's something we need to look at.
Excellent. In terms of our underwriting approach that we have here in Australia and New Zealand, either excluding parts of the body or things like that, are we seeing the same kind of underwriting approach internationally outside of Australia and New Zealand?
Yeah, we do. And look, the disability products in Australia and New Zealand are unique to the world. I think we have probably the closest you get is UK and Canada. Parts of Europe have much more generous contracts, and the US just rely mostly on their social security systems and things to do it. So our guidelines are global because we do use our evidence base to do it. But we do have certain conditions where I guess we are sort of moving towards, can we do a loading? And it is a little bit of I say it's a test and learn, because then they will start to show up in your experience, and you do need to be prepared to do that. But at the moment it is that we do continue to exclude. We've got new legislation coming through with the Life Code in Australia, which is really mandating that underwriters provide more accurate exclusion review periods. So I think it's often just a bit of a set and forget, but the onus will be on the insurer at the time of underwriting to make sure you communicate a review period, and really encouraging people to re-engage with their contracts and see whether they should be long-term conditions on there. So it'll be interesting to see how that goes, because we could, ultimately have someone that we've reviewed an exclusion at 2 or 3 years, and then they do reappear for a claim on that specific body part. What does that mean, and what will we learn from that? Is it a recurrence of what the condition was, which we were trying to exclude, or is it something completely independent as well?
Excellent. And we've had discussions, I guess, around orthopaedic conditions such as spinal stuff and hip replacements, but I think we're also seeing a trend in osteoarthritis. People that are applying for insurance with osteoarthritis, and I guess anecdotally we're starting to see a lot more of them come through the application process. What do you think that there's a general correlation between us, for example, living longer or obesity, and the rise in osteoarthritis?
Yeah, I mean, I think that all those factors, you could divide osteoarthritis into two broad categories. There's the familial, the inherited, and then there's the post-traumatic arthritis, that if you're a 30-year-old soccer player and rupture your anterior cruciate ligament, I can guarantee in 20 years' time you're going to have osteoarthritis of your knee. But then people have genetic tendencies to that, and osteoarthritis predominantly affects hips, knees, neck, and hands. So obviously they're joints that we may have to replace at a later date. But underwriting time, I think we have to underwrite what's in front of us, really. We can't do anything. And as Ingrid said, is it better in a way now to have loadings rather than exclusions, and it may well be. And we need to look at people's illness behaviour and how they react to certain situations. But because, you can get back to work, all of us who mostly do sedentary work, and if I had a hip joint replacement, there's no reason why I couldn't be back at work at 2 weeks. Okay, you might want to have a crutch for a while, and we'd encourage people to do that, because it's unsafe to have long periods of time off work. Your health deteriorates, psychologically and physically. So it's very interesting. But at the moment, if you've got a gammy hip, we tend to exclude that. And you could argue you shouldn't exclude both at the same time, because it's going to happen on the other side if you.
John can work in underwriting. I was just going to say, we'd like to exclude both hips. And some.
Yeah, for that reason, yeah. I'm not an underwriter.
No.
You're right. And Ingrid, I think one of the causalities of the current disability issue and the sustainability of it is occupational creep, and how we approach people's occupations when taking into account some of the musculoskeletal issues that they've had in the past. Do you think that as insurance providers, we might be a wee bit guilty of allowing occupational creep at all when underwriting applications?
Yeah, look, typically you just need to know if they're white or they're blue, but we tend to have now 8, 9 different occupation categories, and your advisors are looking to, what is the differential, and can they get a better offer for the client as well. So when we look at the different experience across the two, quite obviously your blue collar, when it comes to musculoskeletal, because of their need to be able to have a physical functioning, are on longer term claims and they have the expected experience, but at a higher price. With white collar, you do get some exceptions, like doctors. Calling you out, John. No, you do start, because typically they are white collars, but often you will see them pulled out as a separate category for that reason, because they too need that physical functioning part of it. So when you do have a construction manager who is now completely off the tools running the job site, and we give them probably a more generous decision because we look at their duties. Rest assured, if their team doesn't show up and the job needs to be done, they will be on the tools. If there's a downturn in their business, they'll be back there. So we do need to make sure that we really give those occupations and try and think both long and short term around what could be the implications of those conditions as well.
Excellent. And I believe we are nearing our end, so we'll take any questions if we have them.
There's 4 come through on the tablet.
4 questions? Excellent, thank you so much. So we'll tackle the first one. So this is from Evan Kavanagh. With changes to work habits environments due to COVID, are you working from home and flexi working? Has this had any material effect on claim duration and on assessment of both medical and occupational factors at underwriting? Very good question.
Yeah, it is a great question, and I think we used to always have this standard question, do you work from home? And then we ask you how long, and then we ask you if you've got a separate entrance to your home hair salon, because I think the idea was that people were going to go into their house and work, and we wouldn't know and be able to manage a claim, and they would be taking both their income and a claim. And that was what I got taught all those years ago, why we had this approach in underwriting. But we've been able to have, I guess, the facility to work from home for a long time, but we've also got, I guess, surveillance is a completely different topic, but we do have digital ways to try and help understand if someone is legitimately doing that, and I think that as a risk has fallen off. But I think now we've probably got sort of new risks around people that perhaps have a real preference for working from home. They've got a new tension in their workplace. What are we going to see there? Is that going to become and I say a mental health claim potentially because they're in this environment where they're being forced to return to the office? So it's, I guess, a bit of a moving piece to understand what it is. I think during COVID we had to try and understand how people were being impacted when they were applying for income protection, particularly during that time. So we did have different restrictions and limitations to try and manage it during that, I guess, the acute phase of that.
Excellent, and this is probably a question more appropriate for Dr. John. Is there a correlation between patients having long delays in getting ACC assistance or decisions and the overall prognosis of their condition?
The short answer would be yes. You know, I mean, obviously, ideal in my private practice with a lot of elite patients, and they'll get injured on Saturday, they'll be operated on Monday, return to work very quickly. In the real world, my other patients, they then have to wait, you know, a long time to get seen by somebody. They take a long time to get ACC approval, and there's a delay. So what can be a minor, you know, meniscal injury in the knee, which you could be back in 2 weeks after surgery, it might take them 3 months to even get their operation done. And yes, there will be a longer delay. So we've tried to convince us medically, ACC especially, to sort of get instant approval, get things done quickly, use the private hospitals on the weekend and get some of the wait list, you know, dealt with, but falling on deaf ears with a current government.
Excellent. And I guess for Ingrid, this next question is probably more relevant to you, but can you please expand on the BMI link between underwriting and claims, specifically how the claims experience would alter current underwriting practice?
Yeah, look, it's some early thinking, and I guess the naivety of the underwriter and me just assumed because we ask for BMI on an underwriting application, it would be a standard part of a claim form, because it would be really useful to help with some of those recovery, or to at least, when we start measuring your reserves or how long we expect someone to be on claim, we know that we do have information around the expected recovery times when you're dealing with someone, particularly like a knee or an ankle or a hip. Do we need to give an extended recovery time, or do we need to do a different style of rehabilitation? Perhaps I can think of an aqua program for someone versus something else. So what it is just I think it was a very good lesson, because what we were wanting to do as well, and it's important that we have evidence to support our BMI guidelines. So we look to the claims for that and that experience. And so making sure is, can we actually get some meaningful information to really help, you know, like you asked before, should we be changing how we underwrite musculoskeletal? We need to be able to have some of that knowledge and the impacts into claims to do that.
following on from that, there's a lot of data around and showing that all-cause mortality and morbidity is increased by a high BMI. I mean, you can argue how useful a BMI is, and does it really reflect body fatness or not? You know, when, you know, Richie McCaw would have had a BMI of 31, 32, and he's hardly obese, you know. But it is a useful parameter. You know, we know that smokers will recover slower from most orthopaedic interventions. And unfortunately, I'd say this with some diffidence, that women generally take longer to recover from orthopaedic procedures, and that's an unequivocal fact.
You can have that one, John.
I'm not trying to justify it. And I was rather scared to say it.
And we've got one last question here before I open the floor to anyone else that has any. With increased musculoskeletal claims, are you seeing idiopathic musculoskeletal issues where a diagnosis has not been landed on, or do the claims tend to be due to a specific diagnosis?
I'll take that question. Yeah. Idiopathic just means cause unknown. A lot of things in medicine we don't have a precise diagnosis, so people can have lower back pain, for instance, and we don't know the cause. All the scans are normal, and that's why most lower back pain in the community, we don't find a cause for it, and most of it settles down in 2 to 3 weeks' time. So whether you go to an acupuncturist, a physio, an osteopath or a chiropractor, or go to your doctor and just get some anti-inflammatories, the majority will settle down, and there's not much difference in the treatment between all those groups. We sometimes struggle that people have joint pain or diagnoses which are unclear, and they'll have shoulder pain we can't find a cause for. Neck pain is another one. You know, spinal conditions are quite common for that. So, and obviously it's harder to treat those because we don't know what we're treating. And so we then have to take an empirical approach and say, well, okay, let's try this approach and see where we go from there.
Excellent. All right, does anyone else have any other questions?
Sorry, I'm glad you did that because it's an old man thing to say. I didn't want to type it out. But from a clinician's point of view, with the claims hat on, if a patient presents to you with or without surgery in pain, perhaps not to the point of chronic regional pain syndrome, but I'm in pain whether I sit, whether I stand, whether I walk, and they're not going to cause themselves any further structural damage, are you encouraging those people to stay at work, or if it is coming to a claim time, are you recommending the case managers engage with the medical professional to say this person should engage in work? Because if you're in pain with or without activity, staying at work is a better outcome, certainly, for the person.
I'll answer that question in a couple of parts. If the condition is such that they can do their job still, I would certainly encourage them to do that. There's no being at home off work in itself is not a rehabilitation option. You know, it doesn't do you any good. There are some conditions where you may have to have rest because of certain things, but if there's no medical evidence to back up that rest is important, then you look at if you've got a chronic or regional pain, you may be on medication which may or may not affect your performance. You know, if you're on gabapentin or amitriptyline, some people find they can't, tolerate that and their cognition gets affected. Obviously, when people are on stronger medication, that can be affected. So I'd say be on a case-by-case example. I have footballers who will go and play a rugby game with a broken, hand or something like that. And part of the job sometimes is me to say, will they make themselves worse? And I'll say, no, you won't make yourself worse. It'll hurt like hell. And I had a player last week who broke his nose the week before, and he wanted to play, and he played. And, he got to hit the first tackle again, but he didn't do any long-term damage to himself, So it's that scenario. So you've got to judge each case on its merits. But generally, work...
Like if they can stay,
getting back to work is very important. Having prolonged periods off work is bad for your health, generally. Sorry.
No.
Go on.
Excellent. I think we might have time for one more if anyone has any. Yep.
Just going back to occupationally risk profiling, when we're talking specifically about back pain. Now, historically, we've always thought about manual occupations being quite a high risk factor, but I'm interested to hear what you think about actually sedentary occupations perhaps being a risk factor specifically for back conditions.
Yeah, the high risk groups for us are teachers, people in the medical profession, midwives. You know, you can almost profile the occupations, which you could argue midwives is sort of semi-manual, you know, as well. So anyone in the medical profession, those sort of, you know, people are high risk with back pain. And then going back to your question, the ones where we haven't got a precise diagnosis are even worse. Like if you've had a back injury 30 years ago, had a disc removed and you made a full recovery, but if you've had non-specific back pain, i.e. we don't know the cause of it, that is a real risk factor irrespective of your occupation. So they're the people I'd be very concerned about.
Excellent. Well, thank you everybody for attending. I think we're running a little bit over, but thank you very, very much for coming. So thanks again to Ingrid and Dr. Mayhew as well. So round of applause for two speakers.